Hey everyone, and welcome to The Explainer. Today, we're tackling a seriously intense area of pediatric emergency care: bites, stings, and envenomation. You know, as clinical providers, it's incredibly easy to get tunnel vision when you're looking right at a massive, swelling, totally angry-looking wound on a child. It just commands your attention. But our primary goal today is to master the absolute most crucial clinical distinction in this whole field. We have to learn how to instantly recognize the difference between a highly distracting local wound and a completely unseen, life-threatening systemic emergency.
So, here's our mental roadmap for today's deep dive. We'll start with systemic reactions and anaphylaxis, then cover insects and tick bites, spiders and scorpions, rattlesnake protocols, animal and human bites, and finally, wrap it all up with a comprehensive review.
All right, let's jump right into part 1, systemic reactions and anaphylaxis.
To truly apply the golden rule of pediatric envenomation, you've got to clearly separate a basic local reaction from a full-blown systemic life threat. A local reaction, even a really large, nasty one, might involve a super itchy wheal, it might be hot to the touch, and you'll see painful swelling that gets worse over a few days. But here's the kicker: the patient's vitals remain totally stable. Anaphylaxis, on the other hand, that means airway swelling, sudden difficulty breathing, dropping blood pressure, and rapid multi-system involvement. These are the life threats that demand your immediate, absolute clinical priority, completely regardless of what the actual bite site looks like.
No matter how dramatic or visually distracting the physical lesion is, you must secure the airway, support their breathing and circulation, and get that epinephrine on board first if you even suspect anaphylaxis. The clinical reasoning here is pretty simple but absolutely profound. Local wound care never, ever takes precedence over a crashing patient.
Moving right along, Section 2, insects and tick bites. So, there's a huge spectrum of reactions to bees, wasps, and fire ants. While the vast majority of stings just cause uncomplicated local reactions, a small, red, painful, swollen wheal, we have to always be hypervigilant for systemic progression. If a child suddenly develops generalized edema, or if they start experiencing nausea, confusion, or show any signs of shock, well, that simple local bee sting has just escalated into a systemic emergency requiring epi.
Okay, let's talk about tick removal. You want to follow these exact chronological steps. Grab the tick down low with tweezers. Pull straight upward with steady, even pressure so you get the entire tick, and then thoroughly disinfect the site. And just as importantly, you absolutely must ignore all those dangerous, unsupported myths. No burning the tick with a match, no twisting it out, and definitely no suffocating it in petroleum jelly.
Now let's look at the timeline for Lyme disease, which is caused by the Borrelia burgdorferi bacteria. It maps to some very specific time frames. Stage 1 happens roughly 3 to 30 days after the bite, and that's where you see that classic expanding bullseye rash. But as we transition into Stage 2, around 3 to 12 weeks out, the disease goes systemic. It starts attacking the neurologic and cardiac systems. By Stage 3, which can be months later, we're dealing with advanced systemic involvement, things like severe arthritis and encephalopathy. This timeline right here is exactly why observing a child for 30 days post-tick bite is a strict medical requirement.
Okay, let's shift gears to Section 3, spiders and scorpions.
These two arachnids have completely different mechanisms of injury. The defining feature of the brown recluse is localized, progressive tissue necrosis. It starts off feeling just like a mild sting, but then it becomes this star-shaped purple area and ultimately turns into a necrotic ulcer over 7 to 14 days. Now, contrast that entirely with the black widow. The bite site itself might just look a little swollen and red, but the venom is sneaky. It causes rapid systemic and neurologic toxicity. We're talking dizziness, delirium, seizures, and these awful paralytic-type effects. While death is super unlikely, these patients absolutely need antivenom and muscle relaxants.
Scorpions are a whole other level of systemic threat. While most scorpion stings just cause intense, localized burning and pain, the venom, especially if we're talking about the bark scorpion, can trigger severe systemic effects that unfold incredibly fast. You're looking out for ascending paralysis, seizures, cardiac arrhythmias, and even pulmonary edema. Because this cascade can rapidly progress straight to a coma, scorpion stings absolutely demand ICU-level monitoring and antivenom.
That brings us to Section 4. Rattlesnake protocols.
If you're dealing with a rattlesnake bite, these are your immediate first steps. First, keep the child as calm as possible. Limit their movement entirely. Keep the affected extremity lower than the level of their heart, and initiate emergency transport right away while letting the hospital know to get the antivenom ready. Let's break down the physiology here.
Venom travels through the lymphatic and venous systems. Every time a muscle contracts, it acts like a pump, accelerating the spread of that venom straight into the systemic circulation. So by keeping the child completely still and keeping that limb dependent, you are quite literally slowing down the spread of the toxin.
And now for the strict myth-busting protocol. This is your absolute never-do list for rattlesnake bites. Do not apply ice. Do not use a tourniquet. Do not attempt to cut the wound open. Do not try any kind of suction. And, critically, seriously, I cannot stress this enough, never ever try to chase, capture, or kill the snake. Your one and only priority is getting that child to an emergency department for antivenom. The whole catch the snake for identification thing, total myth. Don't do it.
Moving into Section 5, Animal and Human Bites.
So dogs actually account for up to 90% of all animal bites. Because they have blunt teeth and incredibly strong jaws, they tend to cause blunt force crushing injuries. We see everything from severe abrasions all the way to depressed skull fractures in really young kids. Cats, however, are a totally different story. They have these incredibly sharp, needle-like teeth that create narrow, super deep puncture wounds. This mechanism basically injects the bacteria from their mouth deep down into the tissue, and then the tiny puncture wound just seals right over at the surface. It creates this really deceptive mismatch. The wound looks like a tiny scratch externally, but it actually carries a massive risk for deep tissue infection, hidden abscesses, and osteomyelitis.
And beyond the immediate wound itself, cat exposures can also lead to cat scratch disease. It usually starts out as a localized reaction with swollen lymph nodes, lymphadenopathy, right near the site. But it can eventually escalate to involve visceral organs like the spleen and liver. Clinically, this often presents in a child as weird abdominal pain, sudden weight loss, and a persistent fever of unknown origin.
Now let's talk about human bites. Yes, they require meticulous cleansing, and yes, you have to do a full blood-borne pathogen workup. But listen closely. An adult-sized human bite mark on a child is an immediate, glaring red flag. Once you've medically stabilized the child, this objective physical finding triggers mandatory child maltreatment reporting. Your clinical duty in this scenario extends way beyond basic infection control. It goes straight into ensuring the immediate physical safety of that child by getting social services involved.
Finally, let's bring it all together in Section 6, our comprehensive review.
Let's map out everything we've just covered by directly linking the bite vector to its hidden systemic threat. Think of it like a giant puzzle. An insect sting's main risk, anaphylaxis. The treatment? Epinephrine. A brown recluse? You're risking necrosis, which means aggressive wound care. Black widows and scorpions? They risk severe neurological symptoms, meaning you need antivenom and an ICU bed. Rattlesnakes carry a massive risk of systemic toxicity, so you need immobilization and antivenom. And remember our strict never-do list. No ice, no tourniquets, no cutting. Finally, cat and human bites carry massive, deep infection risks, requiring aggressive cleansing and antibiotics. Structuring the information in your head this way allows you to immediately link the vector you're looking at directly to the life-saving intervention.
Which brings us right back to our final provocative thought for the day. As a clinical provider, when you're standing there facing a highly dramatic, necrotic, or heavily bleeding bite mark, are you going to get distracted by the skin? Or are you going to fall right back on your training, assess the airway, and secure the unseen systemic threat first? Remember, the lesion is just a clue, but the airway is always the priority. Thanks so much for joining me on this explainer. Keep analyzing, keep prioritizing, and I will see you next time.